Thank you very much. My name is Philip de Groot, and I will discuss with you today why a possible explanation why the modern thrombotic inhibitors are not a good idea to use in the antiphospholipid syndrome. As you know, the antiphospholipid syndrome patients require long-term anticoagulant treatment. And nowadays we have the direct oral anticoagulants that have been increasingly used in patients with increased thrombotic risk. But current evidence suggests that DOACs are less effective than vitamin K antagonists in preventing arterial thrombosis in patients with APS. And many organizations, amongst others, the ISTH, the International Society of Thrombosis and Hemostasis, has advised that DOACs are not considered a valid option for patients with antiphospholipid syndrome. And this is the first publication showing this, and this has been repeated many times in different studies, that this is a study of Vittorio Pengo, and he showed in a study with 60 patients on both sides that in this follow-up, 7 patients with rivaroxaban developed thrombotic complications, and in the patients treated with warfarin, nobody, indicating that rivaroxaban, the 10A inhibitor, is not a good option. So the big question is, why do vitamin K antagonists protect against thrombotic complications, in particular stroke, and DOACs do not? Because they both inhibit coagulation. The first question is then, is DOACs less effective in inhibiting coagulation in the presence of antiphospholipid antibodies? Study did with thrombin generation, and here you see what thrombin generation and picture of thrombin generation, and it is important to realize that fibrinogen formation takes place in when the very first amount of thrombin is formed. So the lag time is basically an indication of the lupus anticoagulant, the most important assay to detect the presence of antiphospholipid antibodies. And here you see that if we added a mixture of antiphospholipid antibodies to normal plasma, you see on the right side that there is an increase in lag time. But if we add the different modern thrombotic inhibitors, so as dabigatran, rivaroxaban, apixaban, or endoxaban, then you see that the thrombotic inhibitors do also prolong the lag time, but the addition of antiphospholipid antibodies is kind of doubling the lag time, so indicating that there is indeed the lag time is still this increased. So there's an additional effect of this lag time. So apparently there's no influence. And we look to another indication of the thrombin generation. The thrombin was formed after the fibrin is formed, and we can measure that, for example, as the peak. Then you see that if you add antiphospholipid antibodies, that the peak is decreased. The thrombin inhibitor dabigatran does not influence the peak, but you can see the antiphospholipid antibodies still work. And the 10A inhibitors decrease the peak, but if you add antiphospholipid antibodies, the peak is further decreased. So apparently, there is no influence of DOACs on the function of antiphospholipid antibodies and vice versa. So there is no mutual influence on each other. So the DOACs, what we just see is that DOACs prevents less effective only at arterial thrombosis. So the important question is, are platelets responsible? Because we know that platelets are involved in arterial thrombosis and much less in venous thrombosis. So are platelets involved? Probably. Well, one of the important differences between the use of DOACs and warfarin is that warfarin treatment decreases the level of clotting factors, amongst other prothrombin. And one of the antibodies that is present in the antiphospholipid syndrome are antibodies against prothrombin. So prothrombin is one of the antigens involved in the binding of antiphospholipid antibodies. And is it so that if you decrease the level of prothrombin, that the antiphospholipid antibodies can work less effective? But unfortunately, data on the role of antiprothrombin antibodies in platelet activation are very limited. And the most important reason probably is because we always studied platelet aggregation in the presence of citrated plasma. And we know that prothrombin needs calcium to bind to platelets, and there's no calcium in citrated plasma. So we decided to study the interaction of antiprothrombin antibodies with platelets in the presence of calcium. And to do so, we had a panel of monoclonal antibodies that we have raised against prothrombin. In fact, we have raised them against F1+2, which is the activation peptide of prothrombin. And so these antibodies do not recognize thrombin, they do not influence the activity of thrombin, but they are directed against the activation peptides. And of these 6 antibodies, we found that 2 of these antibodies has a lupus anticoagulant activity and 4 has a no lupus anticoagulant activity. So we have 2 groups of antiprothrombin antibodies that one group has a lupus anticoagulant activity and the other group hasn't. So we started the studies, and to our surprise, we found that the antiprothrombin antibodies do induce platelet aggregation, as you can see, but only those 2 that has lupus anticoagulant activity. The 4 of the 4 that has no lupus anticoagulant activity do not induce platelet aggregation. So only the antiprothrombin antibodies with lupus anticoagulant activity induce platelet aggregation. Was calcium indeed essential? Yes, it is. Here you see an experiment in which we compare the platelet aggregation induced by antiprothrombin antibody in the presence of absence of calcium. And you can clearly see that if you do not add calcium, there is no aggregation. And if you induce calcium, there is aggregation. So we have missed this effect for a long time because we normally use platelet aggregation in the absence of calcium. If you make a dose response, if you see an antiprothrombin antibody in different concentrations, you can see that the more antibody you use, the more aggregation you see. So apparently the titer of the antibody is important for the effect of the aggregation of platelets. What is of course the most important question is, if you have lower prothrombin levels, do you then also have less aggregation? And here you see a dose response of platelet aggregation with increasing concentrations of prothrombin, decreasing concentrations of prothrombin, and you can clearly see that if you have lower prothrombin concentrations, you have less aggregation. And 0.2 micromolar prothrombin is about the level of prothrombin you have when you are treated with warfarin. So you can clearly see you have a 60% reduction in platelet aggregation if you treat your patients with warfarin because you have less prothrombin. So what we can say is that in the presence of calcium, antiprothrombin antibodies with lupus anticoagulant activity induce platelet aggregation. The extent of aggregation depends on the antibody concentrations, and lower prothrombin levels attenuate the aggregation. So it can be an explanation for why, if you treat with warfarin, platelet thrombotic complications are inhibited. The next question, of course, is what is the mechanism behind this antibody-induced aggregation? I don't ask you to completely understand this slide, but this is a slide showing all the different receptors present on the platelets that are involved with different ways of aggregation of the platelets. And with all these receptors, I have also indicated all the inhibitors we have used to show the function of these receptors in this aggregation of platelets induced by antiprothrombin antibodies. And the first thing we checked, of course, is whether glycoprotein 2B3A is involved. And when we add integralin, you can see that the platelet aggregation is completely blocked if you induce that with antiprothrombin antibodies. So glycoprotein 2B3A is involved in the antiprothrombin antibody-induced platelet aggregation. So that indicates that the antibodies do not induce platelet agglutination, as Willamette factor does in the presence of ristocetin, but it really induces platelet activation and aggregation. The next receptors we used are the receptors for thrombin. Thrombin has 2 receptors on the platelet, PAR1 and PAR4, and we used the 2 inhibitors for PAR1 and PAR4 to see whether these are involved in the aggregation of platelets induced by antithrombin antibodies. And you can see here that if you add both inhibitors, platelets still aggregate in the presence of antiprothrombin antibodies, indicating that PAR1 and PAR4 are not involved in the antiprothrombin antibody-induced platelet aggregation. The next thing we checked is whether we can also inhibit this platelet aggregation by different inhibitors that are also being used in the clinic. And the first one is we try to inhibit prostaglandin synthesis with indomethacin, and you can see that if you add indomethacin, the antiprothrombin antibodies-induced platelet aggregation is inhibited, indicating that you can inhibit this platelet aggregation with the classic aspirin or indomethacin type of inhibitors. We also checked, of course, if you block P2I12, whether that can also be functional. And indeed, if you use ticagrelor, then you can see that platelet aggregation is inhibited. So antiprothrombin antibodies can be inhibited by the classic P2I12 inhibitors. So if you think of treatment of this effect, both, at least in vitro, both inhibitors that are used to inhibit platelet aggregation, the way via prostacyclin or the way via P2I12, can be inhibited. So that is functional. The next step, we start to look further which receptor was involved. And the first thing we used was a Syk inhibitor. And the Syk inhibitor completely blocked platelet aggregation. So platelet aggregation induced by antiprothrombin antibodies can be completely inhibited by a Syk inhibitor. That's an indication that the tyrosine phosphatases are involved in this aggregation. So we use the SERK inhibitor. And again, you can see that if we use the SERK inhibitor, platelet aggregation induced by antiprothrombin antibodies is completely inhibited by the tyrosine kinase inhibitors. So suggesting that there are 3 possible receptors involved in this signal transduction, because there are 3 receptors on platelets that are signal via tyrosine kinase inhibitors, tyrosine kinases, and that's CLEC2, the Fc gamma R2 alpha, and glycoprotein 6, the collagen receptor. If you look to these receptors and you think about antibodies, then number 2, the Fc gamma R2 alpha receptor, is the most important candidate. So what we did is we tried to see whether this receptor is involved. And doing so, we use an antibody against this receptor. And you can see in the upper panel that if we use this antibody against the Fc receptor, that you can completely block the aggregation induced by antiprothrombin antibodies, showing that this receptor is probably involved. To further support this, we take our antibody and we remove the Fc part of this antibody by making FAP and FAP2 fragments. And we use the FAP and FAP2 fragments and compare that with the IgG. You can see that if you use FAP fragments, there's no aggregation, and you use the total IgG, there's aggregation. So the aggregation is induced by the Fc part of the IgG. So no aggregation if the Fc part of the antibody is removed, clearly indicating that the Fc receptor is involved. Further, we start to see whether the receptor was also phosphorylated, and if we add, you can see in the upper line that with no activation, the Fc receptor is hardly phosphorylated. But if you add the antiprothrombin antibody, you see a strong phosphorylation of the Fc receptor. And if you compare that with the classic activators of the Fc receptor that's also phosphorylated, well, an activator of CLEC2 and CP6 do not phosphorylate this receptor. So clearly indicating that there is a direct link between the antibody and the Fc receptor. This is showing this again in the diagram. So what is going on? We think that if platelets bind prothrombin, and this prothrombin binds the antibody, and the antibody interacts with the Fc receptor, and you get activation of the platelets. The big question is, of course, to which binds prothrombin on the platelets, but probably that are the negatively charged phospholipids. If you look at these platelets, there is another disease which has more or less a similar effect. If you think of heparin-induced thrombocytopenia, and you compare that with the antiphospholipid syndrome, then you can see that in the heparin-induced thrombocytopenia, it is platelet factor 4 that binds to platelets, and the antibody binds to platelet factor 4, and that activates the Fc receptor. So, and in the antiphospholipid syndrome, it's not platelet factor 4, but it's the prothrombin that binds to the platelets, and then the antibody, and then the Fc receptor. So there is a kind of comparison in the same way as the platelet activation is induced, the heparin-induced thrombocytopenia and the antiphospholipid syndrome. In conclusion, one can say that the antiprothrombin antibodies can induce platelet activation via the Fc gamma R2 receptor. The presence of calcium is essential. The titer of the antibody is important, and low prothrombin levels attenuate the effect of prothrombin antibodies. So platelet aggregation due to prothrombin antibodies could be one of the explanations why DOACs do not protect for arterial thrombosis in patients with APS. Further studies in patients should show that this is true. To stop, I want to acknowledge the people who have helped me with this work, and the most important person is Walid. He works in Maastricht, and he has done most of the experiments, and he has done these experiments with the help of the group of Steve Watson in Birmingham, and the antibodies were raised together with the group in Amsterdam of Joost Meijers. Thank you very much.